Thank you.
This is this. I think we have already seen the obesity thing.
So this
Mostly, it's a rapid recollection of obesity. What is happening? So the obesity, we defined obesity or how common comorbidities, system-wise involvement, pathophysiology, anthropometric measures, and OSA. That is another important thing I have not talked about. So any obese patient coming with pregnancy, the question about OSA and metabolic syndrome is very, very important. And of course, drug dosing principles, challenges in anesthetic management, clinical situation. So this is the definition: abnormally high amount of adipose tissue compared to lean mass, and the comorbidities are diabetes, hypertension, coronary artery disease, and disease decreased life expectancy. So RS, CVS, endocrine, GI tract, so they have more chances of hiatus hernia, gallstones, delayed gastroenteritis. So the chances of aspiration are very high, especially if they are pregnant also. And backache and OA, all these things. And regional techniques are quite challenging in the obese patient. That is another point that we have to remember. And of course, they are more prone for the malignancies, other renal failure, reduced life expectancy. Of course, the pathophysiology of is imbalance between energy intake and energy utilization. So BMR becomes high and fat storage is taking place, and the abdominal fat and hip fat are differently having a metabolism. The abdominal fat is more active, producing a lot of cytokines, and that is why we take the waist to hip ratio as one of the predictors of metabolic syndrome. So if the abdominal girth is more, the chances of sudden death and metabolic syndrome are high. And but that cannot be considered in pregnancy, because unless you see the extra girth compared to a normal growth. Nowadays they with the use of ultrasound they find out the baby size and weight also. So by utilizing that, we can see whether it is a simple abdominal girth increase or whether it is a big baby which is causing this problem. And of course, the cellular disturbance and why they become imbalance between the hunger hormone and the satiety hormone, and mutations, and all these things are more about the pregnancy part of it. And we use the BMI, and ideal body weight is calculated by Broca's index, lean body mass, all these points, waist circumference, waist to hip ratio, tricep skin fold, utilizing this equipment called Harpenden calipers, and then clinical criteria for diagnosing metabolic syndrome, which is one of the causes of sudden death in these patients, and all about OSA, which are very important for stop bank question is very commonly used nowadays, and the investigation needed overnight polysomnography, and treatment is lifestyle modification, CPAP, BiPAP or surgery. So the anesthetic risks are they are sensitive to narcotics, ECG saturation, and biventricular failure if they have not attended to this problem for a long time because of pulmonary hypertension and right ventricular failure. So history of OSA and thorough assessment of OSA is very, very important in obese patient, especially if they are also pregnant. So the stop bank question, what are all the things that you have to ask is snoring, tiredness, observed obstruction or blood pressure. And the bank stands for body mass index, age and neck and gender. And using that we are now calculating the risk also. And there is another scale called Epworth sleepiness scale, which is used with regard to why they become sleepy, because they don't sleep properly in the night. They have daytime somnolence. So how serious it can be to cause any damage to them or to others is very important. That can be used with the Epworth sleepiness scale. And this is the Berlin questionnaire, which is a modification of your stop bank, which is also used nowadays. And of course, the difference between a normal person's body fat disposition between the lean and adipose tissue, in a normal person, it is 80-20. Whereas when you become obese, the adipose tissue level increases, so it becomes 60-40. So drugs which are used should be thought of in water soluble and lipid soluble drugs. So based on that only we do all the drug calculation, which is important. So which drugs of anesthesia we can use on total body weight basis, and the other drugs which we have to use on lean body weight we have to be aware of. And how to first to go for the vascular access, which is can be very challenging. So the central line may be sometimes needed just for volume replacement. And volume replacement in the obese to be done very carefully. Again, you have to cannot rush too much of fluid. So that has to be given only on lean body weight basis, not on total body weight. And uh, especially in the uh, pregnant patients with obesity, you have to be fluid replacement should be done based on lean body weight and not on total body weight is another important thing. And coming to the challenges that you have to take care of is airway, a detailed evaluation, positioning of the patient for both induction and intubation and recovery. You have to use that ramp or help position. Then what monitors you want to use, especially BP cuff monitors sometimes may be inadequate in the arm, so you can use them in the forearm. ECG tracing and APPA SpO2 monitoring. What agents are safe and their drug dosing, volatile anesthetic selection, neuromuscular blocking usage, all these things you have to know. And what technique you are going to use, whether you are going to put a central line or whether you are going to use a peripheral line or whether you are going to use GA or regional. So wherever possible, regional should be the choice. But just because you are giving regional, you should not be very slack, because sometimes if the surgery is not getting over within the regional time, you may have to convert it to GA. So unless you are confident of securing the airway, don't venture on RA because it is much more easier in these patients. And what are all the pain relief that you can use is you have to avoid narcotics as much as possible in patients with OSA and go for multimodal analgesia. And fluids you have to be very careful giving only on lean body weight basis and avoid rapid filling. So all these things are remembered by the mnemonic, a prime minister at a public function. So take the A for airway, P for position, M for monitor, A for agents, T for technique, P for pain relief, and F for fluids. Okay. So some of the clinical situations which we encounter are these three case scenarios which I have given, which are now not relevant here, but the management strategies I have discussed here. Now coming to the same patients with obese patients, the anesthetic challenges are the multidisciplinary team involvement is very, very vital in managing obese parturient. Neuraxial analgesia should be offered early in labor, and continuous neuraxial techniques are optimal for cesarean delivery, and general anesthesia poses significant risk in these high-risk patients. And the maternal and neonatal complications associated with obesity are the maternal complications are gestational diabetes, gestational hypertension and preeclampsia, OSA, cardiovascular diseases, thromboembolism, infection, sepsis, instrumental delivery, failed instrumental delivery, cesarean delivery, postpartum hemorrhage, and longer hospital stay. All these things are maternal problems. Neonatal problems can be preterm delivery, miscarriage. A baby may be small for gestational age or large for gestational age. Either way it can be. Macrosomia, stillbirth, shoulder dystocia. Especially if the baby is a macrosomic baby, then you can expect shoulder dystocia very commonly, which can result in the baby's Erb's palsy or baby's other injury, as well as maternal injury also can happen. Maternal birth canal injuries can happen. Neural tube defects and neonatal death and neonatal ICU admissions are also quite common in these patients. So that is what you have to remember it.
Like inadequate BP cuff size, the length of the spinal needle also has to be assessed for
Yeah, you
especially
have to have very correct. Yes, you have to have extra long needles. You
extra
cannot
long.
reach with the normal needles.
அதுக்கு ஏதாவது criteria இருக்கா சார்? more than weight or எது 80 meters இருந்தா
If
ரொம்ப கஷ்டம்.
no, if the patient is that is why majority of the time it is better to make them patients sit and give the spinal rather than the lateral position. So identification of the midline is also quite easy by pulling the fat apart in the sitting position rather than lying in the lateral position, because the upper side fat will come and fall on the midline. So pushing that and identifying the spine is very difficult. Whereas if the patient sits and usually what they do is they put a plaster and strap and take the flowing back skin into the abdomen for anteriorly, or you can ask somebody to pull it from the front so that you can identify with the nowadays. That is why ultrasound is very much recommended for identifying the midline and going for the blocks.
So also about this epispinal which he spoke about, he said needle within a needle technique. But there is the other technique also where you can give the epidural in one space and give the spinal in another space.
That was the original method. It was
if you don't have, if you have needle within a needle, if you don't have
if
it,
that set, if you don't have, you go for the two different locations. Actually, the original paper that was published was done only like that. They gave identify the epidural space, threaded the catheter and kept it there, and then went one space below and then gave the subarachnoid block. That was the original publication. That is how, because especially a male anesthetist who was bothered by a gynecologist who who was not willing to wait till the epidural took up. So he thought, why not give a spinal and continue the rest of the anesthesia with epidural catheter. So that is how it all came. If you read that original paper, that is how it was published. Two level techniques.
So if an MS case is with the atrial fibrillation only without pulmonary hypertension, is it regional is safe in that?
Yes, if they are hemodynamically stable without any compromise, then you can, if your echo shows no pulmonary hypertension and left atrial pressures are normal, then you can go ahead and give a regional. In fact, regional, originally it was thought very unsafe because it's a fixed output left ventricular function. But nowadays, they say regional is safer because the chances of identifying any fluid overload is much easier in a conscious patient rather than under GA.
And
let me see.
Managing one doubt, sir. Managing a mitral stenosis with a pulmonary hypertension. Presenting for cesarean.
Yeah, I'll just show that. I have another PPT for explaining all that points on you wanted. So I'll just show that also. See, this is a PPT on so here you see mitral stenosis, it has got decrease emptying, decrease in elevated so any increase in heart rate causes all these changes, decreases the filling and decreases the emptying. So left atrium gets dilated, left atrial pressure increases, and pressure gradient develops between LA and LV hemodynamic hallmark, pulmonary congestion, auto transmission occurring during after delivery. All these things go in for irreversible chronic pulmonary hypertension. Okay, so this is how the whole thing occurs. So anticoagulation during pregnancy is you have to go for heparin up to 12 weeks antepartum with an APTT of 1.5 to 2.5 times of normal. And warfarin from 12 to 36 weeks maintained between INR of 2.5 to 3. And subcutaneous or IV heparin after 36 weeks. Therapy with low molecular weight heparin instead of unfractioned heparin is gaining popularity, although an anti-10A activity is used to monitor low molecular weight heparin. No anti-10A activity based guidelines have been issued till date. So that is the reason why LM low molecular weight heparin are not very popular. And there is what is called a CAR-PEG score, that is cardiac disease in pregnancy score, which can estimate the woman's cardiac risk during pregnancy. If it is based on 4 risk factors, so any prior cardiac event like failure or transient ischemic attack, stroke before pregnancy or any arrhythmia, that carries an important risk. And baseline NYHA classification more than 2 or cyanosis. Left heart obstruction, that is mitral valve area less than 2 square centimeters, aortic valve area less than 1.5 square centimeter, with a peak LV outflow tract gradient of more than 30 millimeter echocardiography. So this is a very important finding. And reduced systemic ventricular systolic function, ejection fraction less than 40%. So if you take all these things into criteria, less than 0.5 you have very low mortality rate, but after 1 point it becomes 25 and after 2 points it becomes 75. Very high mortality will happen. So this is the flow volume, pressure volume loop that normally in the exam they may ask you to draw and try to explain. So MS impairs left ventricular filling. So there is decreased end diastolic volume, preload. So decrease in system stroke volume and fall in cardiac output. So reduced ventricular filling decreases ventricular wall stress after load and decreases end systolic volume also. So decrease in end diastolic volume more than decrease in end systolic volume. So there is ultimately a decrease in end systolic stroke volume. So the common question is the left ventricle is functioning normally, but why still there is a decrease in volume? Because decrease in end diastolic volume is more than decrease in end systolic volume. That is the answer for that particular question. And obstetric management, vaginal delivery, tachycardia secondary to labor pain increases flow across the mitral valve, producing sudden rise in left atrial pressure, leading to acute pulmonary edema. So good labor analgesia is a must. So you can go for epidural or combined spinal epidural. And then during vaginal delivery, second stage of delivery should be cut short by instrumentation. Maintain left uterine displacement for good venous return. Supplement oxygen administration with pulse oximetry monitoring to minimize increases in pulmonary vascular resistance, and fetal heart rate monitoring should be carried out. Invasive cardiac monitoring by either radial artery cannulation or pulmonary catheters are beneficial in assessing cardiac output, pulmonary artery pressure for guiding fluid. Patients with NYHA more than 3 or 4 patients. Sudden drops in systemic vascular resistance in the presence of fixed cardiac output can be prevented by small boluses of phenylephrine with volume expansion when necessary. So that is how you manage that hypotension. Then coming to obstetric management, cesarean section only for obstetric reasons, epidural or spinal, combined spinal epidural. So all these techniques are subarachnoid causes a rapid onset of extensive sympathetic blockade with intense vasodilatation, sudden hypotension, which can result in severe tachycardia. So when you plan for a subarachnoid block, it must always be a low volume local anesthetic with a added opioid so that you can avoid the high block and sudden hypotension. And category 1 cesarean section, immediate threat to life of the woman. So within 30 minutes you have to remove the baby. And category 2, maternal or fetal compromise is there but not immediately life threatening. Category 3 is early delivery is needed but no maternal or fetal compromise. Here there is a threat but that is not urgent. Here there is no threat at all but better to do an early delivery. And category 4 is almost like our elective cesarean section, when you can do it at any time. So what are the goals you have to maintain is a slow heart rate. You have to maintain sinus rhythm, avoid aortocaval compression, maintain adequate venous return, and maintain adequate systemic vascular retention, prevention of pain, hypoxemia, hypercarbia, acidosis, which may increase pulmonary vascular resistance. So these are all the goals that you have to keep in a mitral stenosis patient. Now, left-sided obstructive lesions, which include aortic stenosis, subvalvular or valvular coarctation of the aorta, and mild or moderate mitral stenosis. All these things are called Schoen's complex, which can be of, in the Schoen's complex, the mitral valve is a congenital origin, whereas in the rheumatic heart disease, is an acquired disease. So some examiners suddenly, if they ask you what is Schoen's complex, all these 4 components with a congenital mitral valve, mitral stenosis is called Schoen's complex. And left-sided obstructive lesions are preload dependent, yet the patients are prone for pulmonary venous congestion. And gradients across the fixed valvular lesions increase with the physiologic increase in cardiac output, which can lead to pulmonary venous congestion. So by the normal physiological change of increase in the volume itself can cause a pulmonary congestion. That is why patients who have been not having any symptoms prior to pregnancy, they become symptomatic only because of this factor. And then only you detect that they have a mitral valve pathology. So maintenance of euvolemia with judicious use of diuretics may be required during pregnancy and the peripartum period. That is why after the second stage of delivery, before the placenta is removed, always better to give a small dose of diuretics so that you don't land up with a autotransfusion overload. Women with moderate to severe MS who were asymptomatic prior to pregnancy may become symptomatic during pregnancy because again I told you about the factor. And echocardiography once per trimester is sufficient. With the third trimester, echocardiogram performed around 32 weeks gestation at the time of peak hemodynamic load. So that is a guideline for when to do an echocardiography. So you have to do at least every trimester once, but the latest one should be done at 32 weeks when the maximum load on the heart is there. Metoprolol, propranolol, and diltiazem are safe to use for rate control in pregnancy. Diuretics such as furosemide may be used to decrease pulmonary venous congestion, but care should be given to avoid over-diuresis and hypovolemia because these left-sided lesions are preload dependent. And mitral valvuloplasty can also be considered in severely symptomatic patients who are refractory to medical management, but with favorable anatomy. That is valvuloplasty by either a balloon method or simple open method, or if the valves are not fully calcified and if the leaflets are still pliable, then they can be attempted. If surgical intervention is required during pregnancy, intervention during second trimester after organogenesis is complete and prior to fetal viability around 20 to 22 weeks is generally recommended to maximize fetal outcomes. So that is what being recommended. But if you want to go for a cardiopulmonary bypass and full replacement, then you have to wait for the final term. Okay? And prosthetic valves are there, mechanical valves, long acting. So valve replacement surgery using cardiopulmonary bypass can be done only in the third trimester. Because all these things are mostly with regard to the mitral stenosis case only. Okay? That's what. Okay. I think I am through.
Thank you, sir. Thank you. Any more doubts from the students?
Sir,
Dr. Arun, any doubts?
sir, when there is a hypotension with mitral stenosis with the pulmonary, there is Eisenmenger syndrome.
Eisenmenger is reversal, complete reversal, you know, that is the flow reverses from right to left.
Right to left.
Yes, sir.
Eisenmenger normally doesn't happen unless you have a communication, like your VSD or ASD. In mitral stenosis, you won't get that problem. You will get mainly pulmonary congestion and edema only. You won't get any reversal of flow from the right side to the actually there is because of the high pressures, left atrial filling gets decreased over a period of time because of the congestion always occurring in the lung. Fluid gets retained in the lung more.
Severe
That is why
MS.
the always the drug of choice is phenylephrine because it causes pure alpha agonist action with reflex bradycardia, which is very useful in mitral stenosis patients. So instead of ephedrine, you go for phenylephrine, either infusion or intermittent boluses, whichever way, depending upon the hypotension.
Can it be used with a severe MS with a pulmonary hypertension or RV dysfunction, sir? Is phenylephrine or any other?
No, RV dysfunction, if you have, then it is better to go for a drug like Melrinon. RV dysfunction is always better to manage with a Melrinon or dobutamine, not with phenylephrine, yes. Okay.
Thank you, sir. Thank you,
Thank you, sir.
madam.
Thank you. Thank you.
Can I add one final take-home message, sir?
Yeah.
For the students, the students, like as you said, I'm just summarizing what you have already explained, sir. For a patient who did not have even a single episode of paroxysmal nocturnal dyspnea, and with the echocardiographic sizing of mitral valve more than 1.5 centimeters square at 32 weeks of pregnancy, and clinically asymptomatic, a safe anesthetic technique will be a spinal anesthesia with 1 ml of hyperbaric bupivacaine with 10 to 20 micrograms of fentanyl added.
Correct.
Yes, sir.
Yeah.
And sir, next week, can we have a cardiac case, sir? Some ASD of a pediatric age group?
No.
ASD or VSD?
Oh, you want congenital heart diseases, huh?
Yes, sir.
Okay. Yeah, we can have that, no problem.
What examination, what cases usually now they are keeping, sir? Like ASD or VSD, sir?
More commonly, VSD will be because that is more prevalent than ASD, but we can extrapolate and discuss both on that. We can present whatever we want, but we can discuss all the congenital cases in one shot.
Okay, sir. So next week case will be a 8-year-old male boy with recurrent respiratory infections for VST correction.
Right.
Okay, sir. Thank you. Yeah, yes, doctor. Somebody is asking some questions. Sir.
Spinal buprenorphine is safe with a single shot spinal for obstetric in postpartum period.
Addition of buprenorphine in the spinal
Maternity.
As a subarachnoid injection, is it?
Yes, sir.
Yeah, you can do, but with a very, very guarded dose. It can have a prolonged effect compared to fentanyl. Fentanyl is a maximum 3 to 4 hours of action. Whereas buprenorphine, if you don't give the correct dose, can produce late respiratory depression after even 18 hours. So
What is the peculiarity of buprenorphine respiratory depression?
Peculiarity is it's a very late one, and second thing, the pruritus nose is very, very high with buprenorphine.
Asking Purnima, sir. Asking Purnima, sir.
Purnima, okay. I thought you were suddenly asking this.
Anyone?
What is the peculiarity of using buprenorphine? And sir is saying you have to be very, very careful using buprenorphine because it produces late respiratory depression. Another very important point is it is not very easily reversible with naloxone.
Yes, sir. Yes, ma'am.
You can relax. You can even get back morphine, whatever. Any narcotic can be reversed. Whereas the respiratory depression produces by buprenorphine is not easily reversible with naloxone. Do you know why?
It's partial agonist.
Very good.
That's okay. So many are partial agonists, but it has a particular reason as to why it cannot be reversed. What is the structure? Just look it up. It's very interesting. That's all. Yeah. It's okay if you don't know it.
Ma'am, neonatal depression, does it cause neonatal depression?
It does. It does. Not because of that. I'm asking you why it's not reversible. with naloxone.
ஒரு வீட்ல இருக்கேன் நானே பண்றேன்.
Neonatal intravascular absorption will be there, some amount of opiate from the spinal.
Okay.
Systemic absorption will be there.
Why can't you give naloxone and reverse it? You can give naloxone, no?
It cannot be reversible. It's not reversible.
Why? That's why I'm saying why. That's the reason. It's okay. Look it up. Too much. It's just to get your brains a little so that you won't sleep. That's all.
Can it be buprenorphine safe? Does it cause neonatal depression? Giving a spinal buprenorphine in obstetric cases, single shot.
No, you can use 30 micrograms safely, not more than that. 30
Okay,
micrograms diluted. That is each ampule is 0.3, which is 300 micrograms. Make it 10 ml. Take 1 ml from that, and you can add that to the local anesthetic. That is a very safe dose.
Yes, sir. Thank you.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, madam.
Good night, sir.
And thank you, dear students. We'll all meet once again next week for a very interesting case of a pediatric VST correction. Thank you, sir. Shall I sign off this meeting, sir?
Yeah, thank you.
Thank you.
Thank you, sir.
Good night, sir. Good night, sir.
Good night, sir.